So once again, we'll be live streaming today's lectures. Just like yesterday, we'll be taking pictures. We may ask you for an interview. And of course, during the event today, if you want to share on social media, you please use the hashtag Pre-Intern 2021. And finally, we just want to acknowledge our grant supporters, Boston Scientific, Terumo, WL Gore, and our exhibitors today. Make sure you visit them again: Boston Scientific, Cook Medical, MTF Biologics, Oroscoptic, and Siemens. If anybody has any questions, needs help, you know the staff's wearing black, and we're here to assist you guys. So have a great day, and see you later.
All right. Thank you, Mariana. So let's talk about the day. So we're going to give a couple of lectures down here. They're going to set the cadavers up. The plan is to do axillary and pulsatile. That's going to take probably most of the morning. In the afternoon, we'll open the abdomen. What we're going to start doing is at lunchtime, Ponraj Chinurdari, he's a physician who works with Siemens. He's going to orient you to the CAT scan. I know we went through some CAT scans yesterday. He's going to really teach you how to actually interact with a CAT scan. He's also going to be running tours through the hybrid room. So much like the ultrasound, those of you who have not done, how many have not done the ultrasound station? Okay, so you'll get a chance to do that this morning. You need to do that before lunchtime because you're not going to be here this afternoon. And then what we're going to do is start doing the same thing with the hybrid room. Ponraj will take you in there, show you all the bells and whistles of the hybrid room, teach you a little bit about radiation safety when we're doing that. And then this afternoon, we'll kind of open the abdomen and give you an opportunity to explore the aorta. What we're also going to start doing this afternoon is opening up the endovascular simulators at one end of the lab. There's what we call the Pontresina models. The Vascular International is a little company that came out of Pontresina. I'm not sure that actually exists anymore. Do you know if they still exist, John? I don't think you do either. Anyway, they built this incredible glass model of the cardiovascular system. It's underneath the hood, and it's got two femoral arteries that stick out the groin. So that'll give you an opportunity to do needle, wire, sheath, and instead of radiation, there's a camera, and you can control the camera. Camera's kind of like the image intensifier. You can slide it. It can go RAO, LEO, and it'll let you actually see how these catheters perform inside a flowing model. You can't put any stents in. Don't put any stents in. Get them out as an SOB to try and get them out of there. But it will let you play with wires and catheters and show you how you select different types of catheters for doing different kinds of access. So again, there's only 3 of those total, and so we're going to, Mariana will basically rotate different groups through that. Meanwhile, you can continue working on the cadavers. Eric, you want to talk about the surgical instruments? As I said, we kind of largely went through this yesterday. We're just going to see how attentive you actually were and see if you can identify. Well, these are just a series of pictures of instruments, and then we'll go through some of the endovascular tools of the trade. Again, outside here, how many of you got loops? Nobody's got loops yet. That's amazing. So obviously there's a loops company. One of the things that maybe you want to talk about loops too, Eric, and your experience with it is I don't know the company who's here. They look like they've got great loops. Mine have been designs for vision, which I'm still wearing the same loops that I bought as a fellow at Emory. It's kind of amazing actually. So it's worthwhile investing in a good pair of loops. If you buy a cheap pair, you can get them for $300 though. I don't know how durable they're going to be, but having something that, the lens fell out of mine about 4 or 5 years ago. I mean, I had it for 25 years, and we asked them to fix it. It came back completely refurbished, a new box, a new name on it, and how much of it? It said, it's guaranteed for life. No charge, which is, I don't know how to make any money, quite honestly.
I think everybody's program is providing loops.
Yeah, go on.
Is that right?
Go on.
Yeah.
Pardon?
Huh? Yeah, I think universally your programs are paying for it. I mean, so our program pays for it. I presume most people, raise your hand if your program's paying for it, or you think they are?
Your program's not paying for it, but
Yeah, didn't necessarily want to call them out, but those online, right? Yeah, I guess I'd emphasize a few things as you guys are doing this stuff today. So dissecting out the anatomy and that stuff is awesome, right? But it's really not supposed to be an anatomy lab as much as a surgical skills lab things, right? And when you're thinking about what are sort of the things you need to get good at, ultrasound for sure, right? You need to be able to work the buttons on that machine, right? Usually the small machines, Sonosites, GE Logic Book, that kind of stuff, right? The small machines. But you really need to be able to do the depth and gain and those things and be able to set that for yourself. You need to be able to do punctures, right? And it sounds pretty straightforward, right? You do it on a model once, you're like, no big deal, how hard could this be? Wait till it's a big person, they're moving, they're hurting, and blah, blah, blah. but you should really have the goal of being the best person at your hospital with an ultrasound and a needle. And if you've got that skill set down, things are going to be so much easier for you all the way through. And I would say it's a skill you continue to refine. I mean, I continue to refine my technique. I know, John, ultrasound guided punctures. I mean, you can't be too good at that, because you're going to have some really hard ones and some ones that seem like they should be really easy, but then they're not, right? And I don't know how many times with either, you know, a student or an intern or a senior resident or fellow that I come by and like they can't get it, right? And almost always, like, the probe's reversed. So they're sticking right, and on the machine, like, the image is going left. I mean, it's simple, straightforward stuff of setting up the imaging right for yourself, orienting yourself, and then, you know, kind of having a plan that you're going to execute, and setting yourself up for success with the ultrasound guided punctures. Really, really important. And try it at different angles, in long view and transverse, because you're going to have people that demand that you do both. And then you really want to get good at suturing, right? For you to not be able to suture well is a real crime. And there's tons of time to practice outside the OR for that. And I would say to you, the single biggest thing about practicing outside the OR is needle handling. Passing that needle from needle driver to forceps and back, and reorienting forehand, backhand, etc., especially with the Castros, crucial. Because people will wait for you to get the right bite. What they won't wait for is for you to reload the needle. I mean, that just drives us crazy. I can't even tell you how impatient we become if you're just fumbling around with the needle stuff, right? So put on some loud music where it sounds like somebody's screaming at you, and then try and pass that back and forth, put it down, pick it back up. Because if you can do that, then you can sew. And the more you're ready to do when you get to the OR, the more you're going to get to do when you get to the OR, right? Because it's just almost unheard of now for it to be like, oh, okay, yeah, let the case take 3 times as long because the resident's going to come and do a lot of it. Man, there's a lot of push on your attendings and the institution, et cetera, to get the cases done and get the cases done well. And you can do that, but you really need to come prepared and really ready to do it. So again, lots of that practice, and that back and forth, reorienting forehand to backhand, just totally pays dividends. Now, John, what do you tell your guys to practice outside the OR?
We spend a little time. And some of you will try to walk around today. It sounds rudimentary and silly, but it really is. We talked a little bit yesterday. It is a sport. I mean, it's a physical sport, and you need to practice just like a physical sport. I mean, it's tennis. You hit the ball against the wall for 500 strokes. In other words, you get it into a habit, because you really, again, we emphasize it over and over. And if you show up to the operating room and you can move along and look like you have some facility with a needle driver, you'll set a positive impression with these people that work with you. And it will translate outside the operating room. They'll trust you on the wards, they'll trust you in conference, they'll cut you some slack when you screw up. If you come in there and futz it up the very first day and you can't really do it, they don't care if you know all the anatomy in the world and have done basic research and have a primary grant. If you can't really function in the operating room, it just makes it harder for everybody. So and it takes practice. It doesn't need a cadaver. You don't need chicken meat. You just really need to spend the time of it's a little bit like the laparoscopic trainer. It doesn't really make sense to take a little cube and pass it back and forth between your instruments. You say, well, that's not taking out a gallbladder, but you have to have that facility to treat that instrument like an extension of your hand. So the more you have one of those things in your hand, and you probably need to practice with both a Castro and a conventional needle driver. And those of you who are left-handed, again, you got to spend even more time, because no one's going to give you left-handed instruments till you buy them for yourself. So, take that time, and again, practice outside the operating room. If the only time you ever pick up a needle driver is in an operating room, that's just not going to work. It'd be like showing up to the Houston Texans and say, I want to be a wide receiver, and you've never caught the ball. You don't know how to catch the ball. Well, if you can't catch it, they can't teach you anything else about the strategy of the game. And if you can't sew, we can't teach you about the strategy of the operation. What's the rationale? What are the directions we're trying to accomplish? What are we doing? You're so focused on just working with your hands that you can't pick up the other stuff. So again, I know we're just hammering the same thing, but practice really matters outside the operating room.
And like the ultrasound guided puncture stuff, I mean, I do tons of dialysis access. Talk about IV nightmares. Those people are disastrous for getting an IV in, right? So I can tell you when nurses can't get it, anesthesia team can't get it, it's me that they call, right? Because I'm the one back and signing pre-op while the residents are starting the whatever procedure it is and that kind of stuff. They're like, oh, Dr. Peden, we can't get this IV. So I do, ultrasound guided radial vein IVs and that kind of stuff. Well, I didn't realize how useful that was going to be until percutaneous fistula came along, and then we're actually doing these cannulations for, distal venous access for that. And that's hitting a vein that's, less than 2 millimeters, so it's a pretty small vessel that you're going for. And that really translates then to doing radial artery lines and that kind of stuff. And again, just the more chances you get to stick needles in something with an ultrasound in your hand, crazy important, and take that opportunity and do it, right? So step up and do those things.
Yeah, so let me jump in. That's probably much more important than exposing the aorta. I know everybody's going to want to open the abdomen, everybody's going to want to expose the aorta. The reality is you're not going to do that for 2 to 3 years. But you can, on day one, be asked to access the groin. And if you walk in your first couple of weeks, show that you're competent with that ultrasound machine. So what do you really need to know? You need to know the probe orientation. You need to know the button.
So stop there. So probe orientation. So Jerry, how do you know probe orientation? Ultrasound probe.
We're going to have to fire Grammy if you
Sorry,
don't
it's
know
Jerry,
that.
right?
So
Sorry, Akeem, yeah.
usually the little,
Was Jerry sitting there yesterday?
Fun?
Was
Yeah.
Jerry sitting there yesterday?
It might have
He
been.
was like right there, right? Doesn't he also have a beard? Akeem?
All right.
Okay.
so there's usually a little knob or dot on the side of the ultrasound that you correlate with the screen to kind of tell you how you are as far as the orientation of the whole.
So the dot on the side of the probe? Yeah, it's a great thing, right? Forget that. Yeah, every manufacturer has its own thing and whatever else. At the end of the day, you want to touch the side of the ultrasound and see when you touch the left, it's left on the screen, right? Now the challenge is your attending or whoever else is showing you may be on the opposite side, but for your eyes and your mindset and your little left-right orientation, you need to touch the left and see it on the left, or touch the right and see it on the right, however you're going to stick.
Yeah, so let me add one thing. The other thing is, if you're the person doing the access, set the machine up so you can see it. And what drives me round the bend is when you come to, and they're going like this. I mean, it's like, what the hell? I mean, you're dead in the water, but it's like you're an idiot. I mean, right off the bat, you're an idiot. I mean, I can't basically teach smarts. You're just stupid. The machine needs to be right in front of you with the screen in your face so you can actually see it. Not
Sadly,
basically.
that doesn't always work out, right? And in fact, you do have to be able to stick it while looking over your back. I mean, your chair of the department, things fall exactly into line and are oriented exactly for you. When you're regular working day job guys, you got to kind of work with what you got. Now you can move some stuff around, but you don't want to be pissing off the scrub techs and all that kind of stuff. You go in there before and set it up, that's great. You can be a part of that, and you should be in there before the case is done, right? You should be in there to understand how they're prepping, how they're positioning, etc. That's a consistent.
So let me pick up on that too. So that was great yesterday, and we're exposing carotid. And I believe me, I've had this. Do you prep your own patient? You set it up?
I did for many.
I know. We all kind of gotten away from this.
Yeah.
Fortunately, they're usually very good. But I was in a situation once that I scrubbed in late to a case, and we're opening the abdomen, and it was like, what the hell? I'm never going to get this thing exposed. And that's because the top drape was here, okay? And the belly was open. I'm like, what the hell? And it wasn't until we pulled this thing, I went, wait a minute, the drape's halfway down the abdominal wall. And once you saw that, and the same thing happened with the carotids yesterday. Everybody's like, I can't get up to the bifurcation. Well, that's because the way these cadavers are wrapped, the drape comes halfway down here. So this is the advantage of being there when the drapes are putting on. Once you've worked with a group of OR staff for a long time, our nurses are superb. They set all these things up. But you can get screwed simply by the way these drapes are being put in if you're not there when you do it.
Oh, yeah. I mean, you go to expose that, and you're like, is that the pillow in the field? Yeah, the pillow they're laying on is like, right there under your IO band and stuff. Happens all the time, right? And you're like, but I was going to go posterior. And they're like,
Not doing that anymore.
Right?
It's not exactly, for you guys, because you're starting at the bottom of the pyramid, you clearly
This will make you feel good.
are nervous about kind of demanding things. But the reality is, you're at the bottom of the top of the pyramid. I mean, you're way up the scale. And when you go into the operating room, if it's going to be to go in and help him put a perm cath in, it's your opportunity to set up that environment for you to succeed. It's not for the circulator or anesthesia or the scrub tech to set up that environment. If you're an orchestra leader, It's your domain. They're all there for you. The only purpose of that operation is for you to be able to succeed. Set it up. Think in advance. Where do you want your imaging? Are you going to stand at the head of the bed to put a perm cath? Are you going to stand at the right side of the bed? Decide that in advance. Think about then, where do you want your ultrasound machine and where do you want your fluoroscopic imaging? You have an opportunity to set that up in advance. Where do you want your lights? Typically, to put in a perm cath, you don't need 3 OR lights banging into the imaging and interfering with your ultrasound. Anesthesia wants to take priority. That's not their priority. It's your orchestra. You're running this whole thing. This is your show. You can tell people, this is how I want it. This is how it needs to be prepped. You can watch them. I mean, I watch 90% of the times that people prep. I'm very particular about how they prep a leg, for instance, and the groin. A lot of times you see them prep the whole leg, get everything just perfect, but they don't really prep what's between the legs, and then they bring the leg back over and contaminate the whole groin before you can get a towel in there and sort of separate things and keep what's prepped away from what's prepped. Then you wind up with a groin infection. You think, oh, goodness, we've got another failure in the groin. But a lot of it is just bad prep, and you're not there. You're the only person in the room that's going to pay the consequences for a badly prepped patient, besides the patient, of course. So I really do think that idea of being in the room, everybody's gotten the same habit, right? Things are going, anesthesia takes them in, nurses do their thing, they call you when everything's ready, and then you sort of show up. You lose a lot of opportunity when that happens. You lose the opportunity to do an urgent trach when somebody can't get intubated. You don't get to see somebody that aspirated when the case got started. You don't really know what's happening, what's going on. You don't see the prep. You don't really know what's part of the prep. You don't know how the thing is positioned. I had one case in my career where when I came in the case, the resident had started the case with an incision for an inguinal hernia. They prepped it out for a left inguinal hernia. It was supposed to be a right inguinal hernia. If you're not there, the train can get off the track. And so I really do think being in the room, you can still do some work over on the side. You got your EMR you can work on, but you can basically, being in the room makes a huge difference instead of waiting until you're sort of called in. So again, think about that as an orchestra that you're setting up for your success. If there's going to be very rare times where an attending is going to argue and say, oh, well, no, this is fouled up. If you've been rational in the way you set up the room for yourself for success, they're going to think that's really good. Trust me, they're going to think that's positive.
I might say July 1st is not the day to show that you've thought it all out, know how the room should go, et cetera, right? I mean, you're going to learn so much more from ancillary staff in your first year than you are from your faculty, probably, that you should really cherish that, right? I mean, ICU care, man, if it weren't for the ICU nurses, I don't know what the body count would be. It'd be huge, right? I mean, that's the reason some people in the ICU, because the nursing is intensive, right? It's 1-to-1, 1-to-2, something like that, and those people know what to do. So you're like, what do you think we should do? Particularly for the gray-haired ones, the ones that got a few wrinkles, have been there for a while, those are the people who want to kind of latch onto. Same thing in the OR, right? They're like, no. Dr. Wright likes it this way. Don't go changing your stuff and whatever, and then kind of paying attention. And when you're doing those cases, I would say, particularly when you're first doing your first set of endo cases, et cetera, get out of that room and write down what you used. Because to know that you used a contra, or no, he likes going over with a Lima, or was it a glide catheter, or burn, or KMP, or vert, or what's the difference between those catheters? The room staff can help you out with that tremendously, but make notes of those things. If you leave there with a surgery log, not just saying banging in a great stent in the SFA, but actually, here's the things that we use. We use a Cook, glide sheath, whatever. Those things really pay off for you. Back to the ultrasound guided puncture thing. So yeah, I'd say the first thing, exactly like Dr. Lumsden was saying, is orienting your probe, right? And again, do that by touching the probe and looking at that on the
So how do you actually do that, Eric? I mean, again, I've never been able to figure out the button thing on the end of it. So, you put the probe down, and then you stick your finger in at the end and go, okay, that's the orientation, it's appropriate.
So I've got the probe, and I'm ready to put it on the patient, right? And I'm holding it like I'm going to put it down, and I'll touch, and I'm like, okay, that's my right, but I see it on the left, so then I'll change it. Okay, it's right, now it's good. And I'm still using the same hand that I'm about to put it down in, right? And although you might do your first scan with your dominant hand, you really need to get good at scanning with your non-dominant hand. right? Because that's the hand that's going to put a shoulder into the gut to get the gut out of your way. It's going to put the elbow on the groin to keep the groin out of the way. And then it's going to be sweeping the probe back and forth so you can see, and you want to orient yourself, right? So next you want to optimize the image, right? So you don't need the image so that it's so deep that the vessel is like stuck at the top and there's all this wasted space. At the same time, you don't want it off the bottom of the screen either. You want it somewhere towards the bottom or the middle of the screen so you've got your depth set appropriately, and then your gain is kind of the next thing, right? So it really becomes orientation, depth, and gain. And obviously we kind of prefer it a little brighter than they do in the vascular lab because we're working under lights like this. In the vascular lab, they're going to have it really dark so they can see subtle grays and blacks and whites and that kind of stuff. But you in general are going to have it bright, but don't have it too bright because then you really can't see your needle. So those things. And then for me next, it's really kind of assessing the anatomy and seeing what's what, right? And I think one of the things that people forget about is if the vessel is running like this, you really want your probe sweeping to where it's perpendicular to that. If the vessel is running like so and you sweep the probe like this, on the screen that thing is dancing side to side like in some 50s dance movie, right? It's like moving on this side of the screen and that side of the screen. Well, the problem with that is if you miss it, which you're going to, either short or far, you're going to be outside the vessel. If you're oriented like this and you're sweeping up and down perpendicular to it and it stays in the center when you move, then you're going to hit the vessel, right? And it might be a little deeper than you thought, a little more superficial. And then lastly, it's seeing the needle inside the vessel. And I like to track it down to it, or at least partway down, not necessarily all the way from the skin down. And I orient myself generally at kind of a 45 and say, okay, I'm 2 centimeters deep. I'm going to come about 2 centimeters back and aim downwards there. What you don't appreciate is how much you can deform the tissue with your probe. And that adds to obviously kind of the complexity of the geometry. But you really want to see that and you want to see. And I'd say kind of the last thing is almost every vessel needs for you to pop into it. Almost always I'll see people, they take the needle, they get it down, and they kind of slowly advance the needle until it itself advances through. Well, most of these vessels are soft, and if you do that, it's just going to collapse, and then you're going to have a back wall, right? And then you can't see the needle, and you'll see some shadow above, and you're like, oh, I'm still above it. Push deeper, right? Until you hit the bone or the bed sheets or something else. And you don't want to do that, obviously, right? So sweeping back and forth, and I call it the sweep jiggy, right? So I'm jiggling the needle and I'm sweeping back and forth to see where is that vibration and where does that vibration stop. And it's very easy to miss, especially in a biggish person. So as I get close to the top of it and I can see that's where I am, then that's where I'll give a pop and actually truly just pop it into the vessel. And if you do those things, then see it inside the vessel, then you're good. With small vessels, you need to walk the needle further into the vessel. You can't just barely punch in, because the bevel is going to be half outside, half inside, and universally when you pass the wire, it's going to coil on top. So again, practicing those things, crucial.
A couple of points is, when you pass a wire, it should be painless. If you pass a wire and the patient starts complaining about it, it's not in the vessel, okay? If you're inside the vessel, they don't feel it at all. And there should be very little resistance to it. And so if you're passing the wire and there's resistance, what do? You're in a hybrid room. You pull in the image intensifier and you look to see where the wire is. You may be in the vessel, but what Eric's talking about is the whole thing kind of balls up to one side of it. You're not in the vessel, you take it out, you hold a little bit of pressure, you can do it again. And so the biggest mistakes that we see, this is the ultrasound beam, this is the needle, this is the tip of the needle, and you think remember, you're looking a cross section of the needle, you think this is the tip is actually 2 centimeters beyond it. That's why he keeps emphasizing finding the needle and watching it as it goes in and make sure it's inside that fan of the ultrasound beam. And sometimes it's hard to see. It's kind of interesting because some patients, it's a piece of cake. Some patients, they must have dense tissue or something, it can be remarkably difficult to see. But if you move the needle, you can actually see even the soft tissue jiggle. You get some idea of where it is.
How many of you have used ultrasound to stick a needle in something?
I bet most.
Okay, all right. So it's not entirely foreign. Yep. It seems to me the thing I see people fail more on is that point you're making of, again, you must either transition or translocate, meaning slide up and down the vessel, or you must be able to fan, meaning to me that means to tilt, to follow that. So on the groin, you can slide the ultrasound north and south to follow the needle tip. In the neck, you can't because the clavicle's in the way. So in order to see the needle advance, you have to be able to fan it. And that's what I see people do more than anything. They kind of use the ultrasound for direction, but then they kind of start looking at the needle to see if they got blood back, because they really are not using it to see the needle tip. So you have to be able to fan that thing to avoid this issue that Alan's talking about. Does that make sense? Does that register with you? Because that bit, you'll have the needle way down in the lung someplace, and it looks like on the screen the bright thing is only 1 centimeter below the skin because you haven't really changed the direction of your ultrasound beam to pick up the tip. And to do that, I mean, one way to do that is to find the tip, fan away till the white dot goes away, bring it back and find the white dot. So you see a flashing white dot in the middle of the screen. As you sort of fan back and forth, that identifies that distal tip of the needle. And continue to use that, kind of combination of movement. But it's not intuitive to be able to do it. The other is, again, this whole issue of orientation. What do the ultrasound techs are always sitting in the same location, but you're not. You're going to be looking how you drive down the highway. It's the driver's view is what you're trying to look at, which means it may be the opposite of what the ultrasound techs typically use. It should look like if you're looking up the groin, that's the way you don't want the head on the top of the screen. In other words, that would put everything backwards. You're looking at it how you're looking at it right in front of you. That's going to depend on where you're standing and where your ultrasound probe is. So,
And again, that's part of the purpose-driven imaging, right? For us, we're doing that for a reason. We're not doing it for somebody to look later and go, oh yeah, I know the orientation is always head to the left, right to the right, et cetera, et cetera. You want the orientation to be something that makes sense to you. Just crucial. And yeah, I mean, almost all of vascular surgery is a two-handed sport. Right? So when that probe is just sitting there on the patient still and the needle's doing this,
Right.
that's clearly the mark of somebody who's either going to get lucky and get it in or is going to miss or hurt somebody. So when you see this,
do you use a syringe on the needle?
almost never.
Yeah. How have
Because
you
then
guys,
you're gonna
do you
futz
use
with getting that
on the
syringe
needle
off.
or not when you've done it? Have you played this? Have you done this game?
No, with the syringe.
With a syringe?
Yeah.
Not with. How about anybody use a syringe? So I personally like using a syringe because my hands are big and they get in the way of each other. So with a syringe, I've got a little extension that gets me kind of up off their face. When I've got to kind of get down in a little spot, it's like working on doing a pediatric pyloroplasty. It's just too much stuff in a little space. So I actually find having a syringe is beneficial to me. Not so much that you see the flash when you pull back and hit the vein, but just for the fact that I've got a little more space to work where my hand's not kind of getting in adjacent to the ultrasound probe. So it's something you could play with and practice and see. Personally, I prefer to do it. Most of our people just use a straight needle.
Slip tip.
If you're going to use a syringe, there's two tips on a syringe: lure lock and slip tip. You can use a lure lock, but you'll regret it because somebody will have stuck it on there, probably you, so tight that when you hit your little fine anterior tibial artery, and now you've got this damn syringe stuck on there so badly that by the time you get it disconnected, you've either lacerated the artery or you've lost your access. So slip tip it doesn't need to be super tight. It's basically just as an extension to make it easier to work rather than the actual, connection.
Yeah, that's a good point.
And once you hit that vessel, it's definitely not the time to take your hands off and start cheering and then get the wire, right? I mean, you need to stay as still as possible when you get that needle in, and particularly in a big groin, that can be really challenging because now, as soon as you let go of the probe, there's an extra 2
The whole
inches
thing
of tissue.
pulls out, yeah.
So that's an interesting discussion, actually, because what do you do? Okay. We used to always use syringes. We kind of went away from using syringes. There are certain situations where it is of value, and that is when you're in a vein and the veins kind of collapse and you're not getting any venous return and you're not entirely sure. There it's very helpful to do it. The overwhelming majority of the time you don't need it, other than it gives you a little bit more working room potentially. By and large, you're in it because you see you're in it, okay? And so what happens is you've got the ultrasound probe, you see the needle, and what Eric says is exactly right. Often what happens is the front wall of the vessel deforms, and you go, poke it, you pop it, it goes in, you see it in. So you see it in first of all, then you look basically for back bleeding. Now the problem with the back bleeding part is we're using a micropuncture set. So on the arterial side, you almost always see back bleeding. On the venous side, sometimes you don't get a lot of back bleeding. but you know you're in from the visualization. Then you take your wire. And so the question is, you got the probe, you got the needle in. How do you do it? What's the transition? I mean, I basically lay the probe down, grab that needle, and put the wire in.
I don't.
I know. So many of the residents basically put the needle in, needle's kind of sticking out, wiggling around a little bit, and then take the wire. Challenge is you got to get that wire in the end of the damn needle, and the needle's wiggling around a little bit, so you got to be pretty good in order to be able to do that.
Personally, I don't move the ultrasound probe. Once I'm in, I leave the ultrasound probe because it's creating compression 90% of the time. Let's face it, most of our patients are overweight, and if you're in the groin, you're, as he's saying, you're fighting the panniculus or something. So once I'm in, I leave it, and I actually like to take that micro wire, and I hold it in the middle of the wire because I don't want to get down close, get a little bit, and have to do this. I find this dangerous because one of the things that happens when you insert that wire is there's a soft tip that's about, I don't know how long it is, 8 centimeters or something, and then there's a transition to a stiff part of that wire. If you insert it like a javelin, meaning you have your needle sitting there and you slide it in as one motion, there's a change in the resistance that you feel when you transition from the floppy part of the tip to the stiff part of that wire, just because it's kind of dragging as it comes out of the needle. If you're doing this, your brain is recalibrating how much resistance you're feeling each time you re-grab and push. Whereas if you make it a single sweep, that all becomes, there's no recalibration. You can feel that transition, and you don't have to worry, for instance, that I'm running into something. Because that floppy tip is so soft, even if it was running into a brick wall, you'd never feel that because it just collapses. So I find actually inserting it in one swoop easier. But again, it's different strokes, I guess, for different strokes.
If it's I'd say if it's a big challenging person, you're having to do the maximum moves, sometimes you actually need a second person to start the wire for you. And then you need to take over as you're kind of introducing it in. But
it's a lot of surgery is about knowing what question you're trying to solve. It's not how you solve it, because we'll all come up with different solutions. It's like whether you pass the needle to yourself or whether you no-touch it or whether you stick it in and take it out. All those things are kind of personal choices, but what you're trying not to do is damage the arterial wall. How you accomplish that's different. You're trying to get the needle and the wire into the vein. Exactly how you do that, the problem is assuring that you're in the vessel. So, if you don't know what the question is, though, that's where you get in trouble, I think. So, and that's part of what we're trying to emphasize today. It's not exactly how you solve the problem, but recognize what problem it is you're trying to solve.
But definitely think of it as a two-handed sport, right? So both hands are moving, whether that's passing the needle back and forth, whether it's doing the ultrasound guided puncture. And I mean, truly, if there's two things you want to get really good at, it's that, right? So Keem, what else when you show up for your first case? What else is going to show you prepared or not prepared?
Did you empty your bladder before you got there?
You guys are young. You can hold it.
For me personally, knowing about the patient, knowing the operation.
Absolutely crucial for you to show up and like, this man, woman, what are we doing here today? Show me, I'm ready to learn. Woo, yeah. Return to back of line. Next. I mean, that's just not gonna fly, right? So for you to show up and not know who the person is a real problem. Dylan, what all does that mean?
What are we doing? Why are we doing it? Where? What side of the line?
Yep. Okay, take it up a level. What else does that mean?
How are you going to do it? So kind of like reducing the procedure down to steps that you follow. So knowing the anatomy, knowing what to do after.
So knowing the anatomy, absolutely crucial. Tell me. Yep.
Yeah, good idea.
So I would say having read about the procedure, right? Now sometimes it's like you had no idea you're going to get thrown into that carotid endarterectomy, so maybe you haven't read. But if you know you're going to go into that, to have read about that, be like, hey, Dr. Wright, I see we're doing the skin crease incision, but I was reading in Rutherford the standard is to come right along the sternocleidomastoid, whatever, right? To kind of approach it, and you got to have some roundsmanship, right? And sort of sportsmanship rules about how much can you ask or not ask, especially early on in your training days. But to say, I've read this, can you tell me what we're up to? Because it seems a little different. I think that's totally valuable, and almost always the person opposite you is being like, wow, this person's actually interested. They actually read about this procedure. I'm pretty impressed. Now, if you keep going on and on about, but Rutherford says, well, then, next, back of the line, right? You're going to kick back out.
Some of you know Erica Mitchell was out at Oregon for many years and is in Memphis now. She put together a thing called Vitals a few years ago, and it was an effort to assess surgical competence, meaning how you guys perform in the operating room. And she interviewed a bunch of senior people and came up with a structure that we've basically just described, but in a little more of a random fashion. And the operative, some of the programs will use this tool. It's called a Vitals tool. But it breaks down, you can't assess somebody's operative performance without assessing their preoperative performance, meaning you must have a conversation with your attending before you are in the operating suite. Now that could be at the scrub sink, it could be at a conference, it could be from a call the night before, but I don't think there's an attending in the world that will think badly of you if you say, hey, I'm assigned to do a such and such with you tomorrow, I'd like to go over it with you. And if you use this structure when you go over a conversation with somebody pre-op, they will think you know something. Sorry. Can you read that? Yeah. So the first thing is the history and physical. Just do you know the facts of the case? And you don't have to go, crazy on it. But what's the history? This patient needs dialysis access. This person needs has critical vascular disease and needs an amputation. But at least know the basic history, the facts of the case. Just the facts, ma'am, just the facts. You need to know the anatomy. What's the relevant anatomy? So just like we were doing carotids yesterday, you kind of need to know the nerves in the neck. It'd be nice to know there's a spinal accessory, there's a hypoglossal, there's a vagus, there's an ansa, there's a big artery, it splits, it's got some branches, but basic anatomy. And then ideally, and this becomes, as you kind of get a little more savvy, is patient-specific anatomy. What's unique about this patient that differentiates them from everybody else? Well, this person had a retroaortic renal vein, or this person has whatever, but unique anatomy for that patient. How do you get unique anatomy? Most of the time, it's go put it in a CAT scan and look at it. And better yet, and Alan's emphasized this a lot, 3D reconstruction is an early tool. I don't know, they're going to do Terra Recon at all this week? Maybe not. Yeah, that may be the time. But there's a lot of advantages with the Terra Recon for looking at operative anatomy, because you can take the skin in and out and see where you may make an incision, where you may not make an incision. Use that thing as a guide to how to do your operation. Rationale. Rationale means, why are we doing
So can I just pause you there? So having looked at the pre-op imaging, that was the thing I was kind of getting to, that I think is just going over, but that's actually crucial, right?
Yeah.
So, okay, this person's got an occluded SFA, but we're doing a BK amputation. Is that okay or not okay, right? So kind of thinking through that process and having that discussion, really helpful and really impressive the people you're working with, that you've looked at the previous imaging, right?
That's kind of that facts of the case thing. It's kind of the imaging, the labs, the data. What's the data that you can't get away from?
And I'm just going to say it again, because you're going to not do this, I don't know how many times. Look at the report and look at the images.
Yeah, that's true. Rationale means, why are we doing this first step? Why are we doing a carotid endarterectomy instead of a TCAR or medical management? And that means based on relevant data. So the sooner you start to think about what is the data, what are the data that are in the literature that are supporting this, every time you think about doing a carotid, you review ACAS data or NASET data or CREST data, and you have that stuff repeated over and over. By the time you finish your program, you know darn good and well what the stroke rate is for asymptomatic carotids at 1 year. You know what the risk is with intervention. So that you start thinking about, why am I doing this? And I think rationale is the best word I've ever heard to sort of put all that in a big basket. Fourth thing would be the steps. That's how to do this operation. Now, some of your programs will be more specific about 10 steps or different ways to do it, but the idea of a stepwise approach to an operative procedure is very valuable. Do you have an idea of what are we going to do tomorrow? And if you can tell your attending, here's what I would do. I'd cut down on the groin, I'd isolate the common femoral artery, I'd make a transverse arteriotomy, I'd put a Fogarty catheter into the aorta, I'd pull the clot out, I would then shoot an arteriogram, and then I'd close the vessel. You have a plan of attack that you now have a structure that your attending can say, well, okay, I like everything about what you've recommended, but here's what I would do in addition, or here's what we would do differently. It gives you a tremendous leg up in terms of how you prepare for an operation. And then the last thing is to think about crisis management. This is the what do you do if part. It's exactly the same. Somebody's in here, I'm sure, as a pilot. The what do you do if is critical to flying an airplane. What do you do if your starboard engine's on fire? Well, you got to know something pretty quick. You've got a lot of skin in the game. And you need to know, well, I need to turn off this valve and stitch this thing and grab a book and figure out what to do next. What do you do if you're doing a femoral exposure and you get venous bleeding because you stuck the right angle into the common femoral vein? Or what do you do if you cut the vagus nerve in half? What do you do ifs? And if you can think about some of those things, what are the critical points before you go in the operating room and discuss those in advance, man, you're way ahead of the game. And use that structure, these 5 steps with phone calls to your attendings, scrub sync, and you can do this in 5 minutes. I guarantee you that any of the 3 of us could have a case with each other and we would run through this almost automatically. And I think it's just a really good structure to think about as you're when you're planning to do a case with somebody.
The other thing that's good about this, Pauline, do you know what the milestones are?
No.
So for the next 5, maybe longer for some years, you're going to be evaluated on milestones, right? Twice a year, your program director and other faculty are going to get together, are going to go over what are called the milestones. And they look at almost this exact sequence of, does the person do preoperative care? Does the person know anatomy? Does the person have medical knowledge? Does the person know crisis management? Almost exactly as John's put it up here just now. They're going to go through and score you on those things, from simple cases to medium cases to complicated cases. And you're kind of thinking through this process, shows progression, and has been kind of marked by the vascular program training groups to say this is how we should evaluate residents. So thinking through cases like this, crazy important. Again, I just say ultrasound guided punctures, being able to manage your needle and handle your needle are going to lead you to success and let you really get off and running. You want to go over instruments some then, Alan?
Yeah, sure. Just do it. Stick them up. So I just point out to them, say, what do we use them for? And see if everybody knows what they are. They did really well, actually, when we showed them the instruments yesterday.
I think number 12 is from horror shows and stuff, isn't it? What do you actually use that for?
You know, that's interesting. That's what we used to use at Emory the entire time to do the arteriotomy. We didn't use an 11 blade. It was a 12 blade we used to enter the vessel.
Yeah, never used one. John, you?
I've never used 12. In fact, it's funny. Have you seen your attendings make an arteriotomy? Which blade have you seen? 11? Is 11 the dominant one here? Anybody use a 15? It's funny, we were taught to use 15s. That's how we opened vessels at the Brigham.
Yeah.
And the idea was you made 3 strokes, 1, 2, and on the 3rd stroke you were to enter the vessel. But remember, again, it's not how you do it. What problem are you trying to solve when you make a hole in an artery? The problem you're trying to solve is not injuring the back wall. With an 11 blade, you do that by turning the blade over, having a low angle of attack, so you're engaging the vessel, but essentially lifting away from the back wall so you don't just stab through the back wall. With the 15 blade, your same goal is not to injure the back wall, but you're doing it in a different way because you're using the pressure of the blade to sort of calibrate how deep you cut. But it's 2 different solutions to the same problem. If you don't know what problem you're trying to solve, you don't know how to solve it. The 12 blade does the same thing. You're trying not to injure the back wall. It allows you to engage the vessel, again, without puncturing into the plaque on the back wall. Trust me, I did one the other day, a damn axillary vein for an access, and I cut the dang back wall by being too aggressive with an 11 blade and just not paying attention because I wasn't being careful enough. So again, we all fail, and you'll have lots of opportunity for failure in your lifetime. But again, it's figure out what the question you're solving first, then figure out the solution that works for you.
I got to say, that's one of the things that's hard to hand over, right, is that 11 blade, because we've seen it so many times that 11 blade means stab straight through, and it's almost like the ultrasound guided puncture, right? is you need to get into the vessel, because obviously it's going to want to collapse or whatnot.
Just because the 11th blade is that long doesn't mean you have to use the whole blade, too. I mean, I've seen people take here, putting in a perm cath, puncturing the skin to make a nice little hole so the perm cath will go in, stab the carotid artery by going, because you can just do it. Well, yeah, if the carotid artery is 1 centimeter below the skin and you got a 1.5 centimeter blade, you can be right in the middle of it. So, you know, again, what was the problem? Well, don't stick. I didn't specifically say don't stick the carotid artery. I was in error as an educator because I didn't make that parameter clear. So identify what the problem is. Don't stick the carotid artery next time.
At the same time, don't make a little needle hole inside the thing, right? Make a nice slit so
Yeah.
you can actually get the pot scissors in.
Yeah.
I mean, I'd say the two problems that I see are somebody stabs
Too
through the
small,
back,
yeah.
turns good case into great case, because now you get to do something on the front wall and the back wall, right? Better to do that back wall repair first, I would say, while you can see it from the inside. So anticipating.
How big of a hole are you trying to make in the artery? How big is that? Are you supposed to, if say your goal is to make a 1 centimeter vasculotomy, whether it's in a vein or an artery, are you going to do the entire 1 centimeter with the 11 blade? What is the goal? What are you trying to accomplish when you first open the vessel? Alan, what are you
want to draw it?
Well, I'm
Yeah.
just,
So, I mean, a couple of things is, if you back wall a small artery, let's say it's a tibial vessel that you're going to do a bypass to, it's potentially catastrophic. I mean, by the time you actually toss in a couple of stitches, that thing's gone from 2.5 millimeters to 1.5 millimeters, may not even sustain the bypass. So it's a pretty big deal. And so John's going to show what you want to see is blood, okay? And you basically essentially put a small stab in the front. If you don't see blood coming out, you're not in it. And so that usually means that you haven't advanced the 11 blade enough into the artery, but that's okay. You'd rather have that than basically through the back wall. And so you're really just trying to make like a 2 millimeter incision in it. You'll see blood coming out of it, even when the vessel's clamped, and then you replace that with a pair of pot scissors. You know what a pair of pot scissors is?
did everybody understand him in English? I can only understand about 3 words.
This is the
out of every
Queen's
10.
English. This is the
I've learned
Queen's
to
English,
interpret.
by the way.
Put a mask on him and I still can't understand it. It's kind of this German thing. I can't really fully understand it. It's very trustworthy accent, but sometimes I don't hear every word. But I think that's about right. Eric, how big a hole you made? He said 2 millimeters.
Yeah, a little bit bigger.
You like it bigger?
So my
3.
point is,
5?
when we go in with the pot scissors, I don't want to spend the next 20 minutes like searching for that hole and then make a second hole,
Yeah.
right? So I'm
So
probably
the
going
problem,
for
what
the
are
2,
you trying
3
to
thing.
solve? You're trying to make a big enough hole to get your scissors in easily. How big is that, whether it's 2 or 3 or 4, but it's not the entire arteriotomy. One of the dangers of doing the whole arteriotomy is, if you're too deep, you've slit the whole damn back wall open. Worse in veins than it is in arteries, just because there's less structure. Yet the point Alan made too, for instance, if I know that this is a tibial vessel, I'll make my arteriotomy on the proximal end of it. So if I jack it up, I've still got decent vessel where my anastomosis is going to fit downstream. Whereas if I make my arteriotomy down here, and now I jack up the back wall, now I've got to go dissect more tibial vessel. I may not have any tibial vessel left. So kind of think about, again, what am I trying to accomplish? I'm trying to get in the vessel, I'm trying to do no damage, and if I do fail, which I may do I have a bailout? How do I get out of this? And one of the ways to do that is to make your puncture point at the least vulnerable part of your whole construction.
Yeah, and I think as you're thinking about it, you should be thinking about those 2 things, right? What's your therapeutic intent and what's the thing you're trying to avoid? Yeah. So don't be surprised when there's like a back wall injury, right? I mean, kind of appreciate that if you're putting in a subclavian catheter, you could drop the lung, right? So complications to me is not about never having them. If it was, we could avoid half of our conferences, right? Because most of our conferences are spent about talking about things we've injured or people we've killed and, you know, whatever that is, right? It's about complications, et cetera. And complications happen, but complications is about knowing it can happen, right? So having that knowledge before, recognizing it when it does happen, because when you sink that 11 blade into the artery, your attendings will be like, ugh. Because they know it's going to happen when you open the rest of it, right? That's going to be right there in the back wall. And you should be kind of thinking that. And then addressing the complication, right? So trying to ignore it or make it go away or pretend it didn't happen, that never works out in your favor.
I had one of my favorite failures was carotid bifurcation. Make a little puncture here with an 11 blade, take a pot scissor, put in the pot scissor, and cut right up here.
Yeah.
just like that, and cut the crotch out of the ICA, ECA. Chomp. That's not easy to fix. That's a really stupid thing to do. And you try to make that happen once in your life. I mean, each really stupid thing you do, you get one of. I've never done that again, and I've never seen anybody do it again, because I'm usually saying, be sure and don't sort of tip your pots up so the scissors are not likely to go into a branch. I mean, you could do it in a profunda if you were trying to go down the SFA a little bit and get your tips of your pots too deep and cut that whole bifurcation point out. Try to avoid those things. Again, where are your points of failure? How are you trying to avoid it? If you drag the scissor in too sharply and not have a low angle of attack as you bring your scissors up, you can get out branches. Get used to it. What's a Dietrich scissor? Anybody heard of that? Everyone's heard of Potts scissors. I don't know who John. Do you know Potts? Who was Potts?
No,
I don't know who Potts was.
There was a John Potts here, but I don't think
Who do you
that's
think Dietrich scissors were? Is it Ted Dietrich? I wonder.
Has to be, isn't it?
I don't know who that. You
Yeah.
know, Ted Dietrich was a very famous cardiac surgeon from out in Phoenix, who died.
That's not true. He was a Methodist surgeon and went out to Arizona and started the Arizona Heart Institute. He was here.
He was a Phoenix guy. He abandoned Houston. But they're the Dietrichs are basically little pots, and they're useful for things like tibial vessels or small vessels, just because they're shorter, and they're in some ways a little safer because the blade is shorter and you're less likely to get out branches. They're harder to use though because you don't have as much blade to work with, so it's easier to cut right to the tip. I usually try to cut just with the crotch of the scissor because you can kind of stay in the vessel as you go forward. If you cut each one to the end, you're having to reset every time you cut it. Of course, the advantage of that is you can't cut too far before you've been corrected.
So what he's saying is you leave the back blade. This is the back blade, and it's inside the vessel. You don't go chomp. Then you got to take the back blade, put it back inside. You cut, you leave a couple of millimeters of the back blade inside the vessel, advance, cut, advance, cut. So the mistake you often see is they go, take the whole vessel out, now you've got to refine the arteriotomy, and every time you do that, you risk creating a dissection on either side of the arteriotomy or entering the back wall.
Vessel wall and pie crusting and separate. Okay.
It's tough as the faculty, though, on that thing, not knowing how far you're going to cut.
Yeah.
So I'm like, only to the end of your scissor. Yeah. Yep. This video you want to show on the needle handler?
Yeah, we've got most of this. You want to just run it? Go back one. And
It's a 5-inch.
That's fine.
The Castros and Riders.
So Castros, we'll see if we get some Castros to let you play with, upstairs today. Go ahead to the next one, because I ran this yesterday upstairs.
It's a 5-inch Hager needle holder, as it is sometimes called a needle driver. In looking at this instrument, a few characteristics jump out at you. One, it has a blunt end. This prevents it from damaging any tissue that it may bump into. The width of the jaws also provides a little extra surface area at the end of the instrument to firmly secure or hold the needle. Note that the joint of the instrument is offset, so that the movement arm of the jaws is quite short. This allows considerable pressure to be applied to the needle, ensuring its stability in the jaws while the suture is being placed. The surface of the jaws is serrated with small triangular grooves. This increases the coefficient of friction to lock the needle in place. This instrument should be held by placing your thumb and ring finger into the rings on the handle. Your digits should not be inserted beyond the distal interphalangeal joint, which will allow you to disengage your finger and thumb easily from the rings if necessary. The index finger can be placed close to the joint of the needle driver, which will allow better control of the tip. Note that when the needle holder is held in this fashion, there are unlimited number of motions of the tip that are possible. The needle should be placed in the jaws of the needle driver, as close to the tip as possible. For these beginning exercises, we will place it in the jaws with a perpendicular angle. The needle should be grasped at a point 2/3 to 3/4 the distance away from the tip. In most cases, the needle should be placed in the needle driver so the point faces you, as you will always try to sew towards yourself.
Any comments?
Yeah, I don't love I don't think those holes are really for your fingers. I mean, you got 5 fingers and 2 holes, and you can figure out where you want to put them. There are times where I don't put any fingers in, right? That's palming. And that's really a power move. That's for doing things like fascia. It's taking wires and putting them through the sternum. If you put fingers, your third finger and your thumb in, that's very delicate because you have great control and you won't have the thing spring open, right? When you unclick the clicker and it just, wildly throws your needle across the room. It's very precise. The problem when you put your fingers in is it limits the rotation. Two things happen. One is you've offset the needle driver from the axis of your hand. So when you're palming, you can rotate around an axis very carefully. You're very unlikely to fishtail and cause damage with the needle. As soon as you put it out in your fingers, you're now arcing. As your hand rotates, you're kind of arcing. So you have to counteract that and avoid more tension on the tissue, more likelihood of tearing the tissue. But you're very precise with your release. And then the combination of either leaving the fingers out and the thumb in, or more commonly, I'll have one finger in and my thumb out, particularly if I'm reaching. You get a benefit in terms of the length of the needle driver. We'll work on this today. We'll walk around and just play with this. Is using your thumb on the end of the hole is a great way if you're down in anything deep and you're trying to reach with your needle driver. You get a lot more length like that instead of having your hand kind of locked in. So again, this is an instrument. It's like a golf club or a tennis racket. Make it familiar. I know I told some of you yesterday, in our residency, it was traditional for all of us to go to the operating room early on and steal a needle driver, and we kept it inside our white coat, hanging from inside the darn thing 24 hours a day. And we would quite commonly take that thing out and just play with it, like if we were sitting at a conference like this, bored to tears. We would sit there and play with that thing and just get it where you can, palming is not intuitive, especially for those of you who have smaller hands. It's not real easy to make your thenar eminence. It's just not intuitive to do that. And but the only way to get that is just like tennis. You keep hitting it against the wall until it becomes intuitive to you. Same thing is true of a needle driver. Make this movement until it becomes part of you. I would advise you to do that. Again, what are you trying to accomplish? You want to be accurate the way you throw your needle. You don't want to tear the tissue. How you accomplish that task, it's what's the problem I'm trying to solve? And then how do you solve it is up to you guys to figure it out. Each of you will figure out a little bit different golf stroke. Each of you have a different stroke with a tennis racket, but you're trying to hit the ball over the net in a smooth way. This needle driver that he showed, none of us would use this for vascular because of a couple of things. One, it's very stiff. These heavier needle drivers that you use on fascia or things that are, sort of general surgery stuff, they don't have any spring in them. One of the things we want is a little bit of spring in the material, so you can kind of feel the needle and you can feel the tissue. If you have when they're too heavy and you got to put too much effort to unclicking them, you lose a lot of your sort of feel for the operation because and we'll talk about this today too, walking around. We don't grab the needle like it's the end of the earth. We've got the needle grabbed hard enough to keep it in position, but we quite often have to change the grip of the needle in the needle driver in the tissue. And being able to soften your jaws a little bit, you need an instrument that's soft enough, that has enough sort of life in it, that you can feel the tissue and the needle simultaneously, so you can kind of move the needle in the jaw. Those are things you pick up as you go. The Castros you must learn how to use. I personally don't use a lot of Castros, and I joke about it saying I believe Castros are basically a crutch. That if you have a bad tremor, get a Castro. And it's kind of true though, because when you use a Castro, Castros are really designed for doing microsurgery. You're sitting there looking at in a scope, and you've got your hands resting on the counter, so you're really moving just with your fingertips. And so there's not as much movement. When you use a Castro kind of in conventional surgery like we do, they do protect your tremor though, because you can keep your elbows closer to your body and you can kind of keep your hands resting on things. All of us have a tremor. Everybody's got a tremor. And it depends on how much coffee did you drink today? How late were you last night? How stressed are you? Are you nervous about this case or you're not? And you get nervous, trust me. I get nervous when I had to do a V3 bypass with a vertebral artery the other day. I didn't have a clue what I was doing. And it stresses you when you don't know exactly how to do something. It may affect whether you've weightlifted. Some of you guys, some of you ladies like to weight lift. I used to lift weights a lot, and I kind of had to quit doing it because I found that if I'd gone out and bench pressed, 30 reps at 220, and then I went in and tried to pick up a needle driver, I'd be doing like that. I'd have a real tremor, and you really have to. I was a friend of mine who was an ENT guy, used to do stapes surgery. He wouldn't carry a briefcase in the hospital on the morning he was going to do a stapes operation because he needed to be really relaxed and have no tension in his muscles. You find, I'm sure, and Alan would say the same thing, we spend a lot of time with our left hand kind of retracting, kind of setting things up for you guys, and then all of a sudden you have to do something with your left hand, you'll have a tremor in it if you've been standing there holding a retractor all day. So I think you kind of have to, all of us have got a tremor, and thinking of ways to kind of, to not hide it, but to control it is an important little tricks. You will see us, for instance, occasionally, we'll use our left hand with the needle, with the pickups to kind of support, and you kind of don't even see us do it, but we're kind of supporting the needle driver with the pickup underneath the needle driver, underneath the Castro. It's another little trick to kind of help to protect yourself from what's inherent. All of us have got tremors. And you'll learn how you deal with it and how you make it better and worse, and learn how to avoid things in the, but the Castro, to me, is easier to control tremor than it is with a long needle driver. Shorter the needle driver, the less tremor you got. You want to show your tremor? Get a long guide point. Get a nice long rider and stand like a spider, put one leg up on the bed, and it's easy to have a tremor when you're in that kind of a position. Whereas you can get compact, get your elbows in, get your body secure, get both feet, get weight on your feet, get in a good body position, you have a lot less tremor.
All right, shout out, what are these? The LPs, superficial, deeper ones. Again, my biggest criticism yesterday is you didn't use your retractors, okay? Think of when you're making an incision, once you start deepening that incision, then you gotta get your hands out of there and get your retractors in. If you get even deeper, then you can use a deeper set of retractors to hold the position. What we had yesterday was you were not using your assistants right. You're continually had the assistants basically holding these hooks to try and have the exposure. You want to free up your assistant so they can use both hands. So appropriate use of retractors is important.
Unless you're trying to keep your attending tied up.
Yeah.
And if you can give the attending a task and tie them up with a couple of retractors, now you can continue to operate. So there are times when you do give people tasks to keep them busy while you're doing surgery.
Yeah, but they're pretty rapidly going to get bored with this, and guess what they're going to do is go, oh my, why don't you hold the damn retractor? So learn how to use the self-retaining retractors. What about this? What was this thing? A rake. What do you call this collection of instruments? What about this one in the bottom? Where did that come from? Where on earth did that name come from?
It's funny, we had a fellow in Greenville that called us the Navy Army.
The Navy Army?
She was a lieutenant in the Navy, naturally, and they refused to call it an Army Navy.
We call these finger retractors, but they're all basically different types of retractors.
The middle one they typically call appendiceal.
What do you call it, appendiceal retractor?
Yeah, and that one on top is a small rich, and it's usually got it's usually 1 inch, and there's a 2-inch piece of it on the other end. That rich is that shape with the little lip on it. There's the 2 and 1 inch rich.
Right, and this one, remember what that is? No, pretty precise, malleable. That's a diva, okay? They come in, all these things come in a variety of different sizes. What do you call that? I call that a vein retractor. That's a malleable. What is this?
It's historical.
It's not historical.
If you see anybody use this, they're from the 18th century.
Yeah, I use it.
He uses it.
Open the abdomen, Balfour in, do the dissection, get the aorta exposed, then put in the Thompson. So that's a Balfour retractor. What about
Did
this?
everybody hear what he said? Balfour.
Balfour.
B-A-L-F-O-U-R. Balfour retractor. This is what we had before we had real self-retaining retractors like the Bookwalter and the Thompson, the Omni. But it's very effective because it does have 3 pieces. There is a little screw on the top, a wing nut, that allows you to put a retainer on that portion. So it's got 3 retraction points. And it can be quite useful when you first open the belly.
What about this?
What part of the body would you use that on?
Sternum.
Sternum.
Sternal retractor. Variety of different types of clamps. This is called an angled DeBakey clamp. This is what I'd call a profunda clamp. We use this all the time. C-clamp. What the hell is that? Satinsky? Satinsky clamp. This is kind of a side-biting clamp.
It's not Statinsky, it's Satinsky. There's 1 T in Satinsky, not 2.
S-A-T-I-N-S-K-Y. Yep. Can you draw a picture of putting a side-biter on?
So
all right.
Satinsky, generally speaking, if this is your vessel, I don't know if you can see that, a Satinsky is essentially a C-shaped clamp that comes down like that. It has the lip is typically about 1/2 inch. So the idea is that you can have enough clamp on the vessel to control this little wedge here, so you can open the vessel here and still have flow through the main channel. It's hard to actually do that. Sometimes we do it. There are other C-shaped clamps that are a little bit deeper that give you more space to work in. They're very hard, especially as a young surgeon, to use a Satinsky with a patent vessel, because the walls of the vessel are still stuck together. There's not a lot of room in there. And if there's any atherosclerosis, it can be very challenging to sort of figure out exactly where the lumen is, because you can't just pull it apart. And so it's easy to pie crust and kind of get your needle not fully in the lumen. But that's the idea, is being able to partially occlude the vessel and maintain flow through the primary channel.
Okay, you put me back up there. What's that? Maybe you know what that is? You know this when you're going your trauma rotation. That's a Lipsky knife and a hammer. So basically, the idea with a knife is that if you're doing an emergency thoracotomy, you cross-cut the chest. That little lip down here goes on the side of the sternum, and it's got a flat back, which you hit with a mallet, and it cross-cuts the sternum. Then you're looking at, then the sternum comes apart, you see the pericardium, you open the pericardium, you get your hand on the heart. You can either do CPR or stick your finger in a hole.
You can do it vertically too. It's harder to do it vertically. But you can. I've seen people use Lebsche knives for an entire sternotomy for like an urgency, the old PE procedure, when you just open up the pulmonary artery without cardiopulmonary bypass to take out a big clot. That's not a likely successful operation.
Yeah. I mean, the challenge with using this to go vertical is if it deviates off the midline, you cut all the ribs off. Nobody's real happy. You know what that is? You know what that is? Penrose drain. When you any idea when you'd use it? Yeah, you can use it for draining abscess. I'm not sure if many people use it anymore. Sometimes we use it to lift something. For example, you make a tunnel underneath the left colon. I use a red rubber catheter, but I used to use a Penrose drain, just wrap right around the sigmoid colon, and you can use it to lift up. That's not used very often. And then we've talked about the vessel loops. They come in a variety of different sizes, and we showed you yesterday, this is how you actually control, a vessel. Tape and collar. So typically, this is one of the things we use in a carotid, for example. If we're going to do a T-car, cut down to the bottom of the carotid, put a tape around it, and then there's a little hook on this. So you've got two pieces of tape, you grab the hook, and you slide that piece of red rubber on the outside of it. And what that allows you to do is you push down on the red rubber, it actually will occlude the artery or control the artery. Similar sort of situation, sometimes you're going to put a shunt in a carotid artery. This is one of the ways you can actually anchor it in there.
A lot of people will use the term Ramel when they're talking about a Ramel tourniquet. Is typically a cotton umbilical tape with a slide, sort of a bolo tie, basically. Slide it down to hold a shunt or hold things in.
All right, what's this? Bud? Alice clamp. Grabbing tissue, elevate things. What's this? Towel clamp, and then there's right angle clamp. Different types of pickups. We kind of used all of those yesterday. These are the pot scissors. These scissors come in a variety of different angles. Some of them are a little more angulated than that. They're almost at right angles. Sometimes you can...
Generally speaking, people will recommend you use something that's got a tooth on the skin. That seems counterintuitive initially, because you're thinking, well, if it's a tooth is for chewing, and therefore I should be chewing up the edge of the skin. But in reality, with a tooth pickup, you have to put less force on it in order to accomplish the same distraction of the tissue. So most people tend to use an Adson or a tooth pickup on the skin, and then when they get down below the skin, they'll switch to a so-called atraumatic pickup. And vascular surgeons tend to use DeBakey pickups because they're, in theory, atraumatic. Everything's traumatic if you squeeze them hard enough.
Cautery. Ever used cautery? They had them working up there yesterday. It's an opportunity for you to actually use them. What's the difference between this and this? Unipolar and bipolar. When would you use bipolar? We almost never use bipolar. The only situation I really use bipolar is doing a carotid body tumor, for example, when you need pinpoint ablation and you've got a bunch of nerves around that you're worried about. But, you know,
What's the advantage of it? So with a conventional unipolar bovie, where's the grounding pad? It's somewhere. So you're going from this generator, electrical current's coming out the tip of your bovie, it's grounding out somewhere through the thigh someplace or on some kind of grounding pad. With a bipolar, the current goes between the two poles, so there is no connection into the system. So it's great in situations where you don't want electricity going throughout the body. So places where you're near nerves, you can get right on top of a nerve and not have any effect. You take a bovie near the phrenic nerve and you'll start seeing the diaphragm jump up and down. If you take a bipolar next to the phrenic nerve, you'll see no movement at all because there is no current affecting outside those tips. If you use a bovie, for instance, in other situations, that's the biggest problem with them. So carotid body tumors, a lot of ENT guys use bipolars, and the deal with bipolars is you don't actually squeeze the tips. You kind of get them adjacent to the tissue, but you kind of leave them apart just a little bit. It's kind of a feel. And you kind of leave them apart, and then typically you activate them with a foot pedal because you don't have a hand pedal here. So you step on a pedal and that activates. It's a handy little thing to play with. And the bovie, I don't know what the purpose of cutting is. A lot of people use it. The idea is it doesn't so-called spray, and these machines have all kind of different settings on them, and there's people that know how to use it actually, but I'm not sure that it's very much kind of a feel thing, I think. What have you heard about bovie use? Anybody have any coaching on bovie? When you use cutting and when you use regular coag? Anybody? Somebody must have
I've
heard.
heard that like the coag function on skin, like they have different functions on skin where like one will burn more skin.
Yeah. Yeah, most people don't like you to use the coag function to cut skin. I'm not sure that's really rational. I think it is. My perception is that you don't really want to burn the skin because you'll get a little, you'll see necrotic tissue 2 or 3 millimeters away from the skin edge. So we don't typically use a coag function on the skin itself. Although, in many circumstances, you'll at least char the edge of the skin. If you got somebody on Plavix and aspirin, you're doing a carotid, and you're just being nagged by little skin bleeders, I personally try to dry it and look for individual spots and touch those spots rather than doing a field effect. All bleeding comes out of the end of a blood vessel. There is no such thing as field effect bleeding unless it's the spleen, which is just basically a giant blood vessel. And there you can use that sort of spray technique where you're trying to arc. But in most cases, you try not to burn the skin. So some people will use the cutting version, though, to cut the skin because it doesn't have as much penetration out into the tissue.
All right, let's move on to endovascular tools. All right, this may seem overwhelming to you. I mean, I would take the opportunity to look at some of these tools outside because there's a lot of them, but they really boil down to pretty common things that you use really on a daily basis. And so you need to know about access needles. We use micropuncture needles for almost everything, okay? So the Micropuncture Kit carries basically an access needle, a wire, micro wire, and a little sheath and introducer that comes along with it. There's a number of different manufacturers of it, and to be honest, I'm not entirely sure which one we actually utilize, but that has replaced all access. We used to use an 18 gauge needle, we don't use that at all. And it's incredibly safe, so that if you actually stick an artery, stick a carotid, by and large, there's going to be very little in the way of consequence from that. So access wire sheaths, just kind of run through it. And so what you will see is in all the rooms that you're working in, somewhere, whether it's in a cart outside or whether it's in the room, there are a whole bunch of things that are hanging up there. And there's a ton of information on these labels. It'll tell you about the length of a catheter. It'll tell you about the length of the balloon. Tell you about the shaft length of the balloon. Tell you about the diameter of the balloon. It'll tell you the burst pressure of a balloon. It'll tell you the burst pressure of a catheter, because you need to know that basically when you hook it up to a power injector, for example. So it's worthwhile spending some time just reading the labels that are on there. We will all get in the situation where you've got a 180 cent, first of all, everybody know that a 180 180 wire is kind of a standard workhorse wire. But when you're going from the right groin down to the tibials in the left, it ain't going to be long enough. You got a 180 wire will get you there, but then you're basically going to take a balloon that's got 110 centimeters on it. It's not, you don't have enough working length for that. So that happens all the time. You're just going to have to learn, when you use long wires like a 300 centimeter wire, and what situations you're actually going to use it. But there's a lot of information that's available in this. So this is kind of what the access needles look like. So you stick with this micropuncture needle. This is the micro wire that goes through it. Then you take the needle out, and then what you do is you put this little sheath. This has actually got an inner dilator and a sheath. Once you put it in, you take the inner dilator out, and there should be pulsatile blood coming out if you're inside an artery. I did mean to say, when we were talking about common problems with ultrasound, we were largely talking about arterial access. You're going to probably do even more venous access. And the biggest problem in the venous side is too heavy a hand, okay? If you basically got a heavy hand on the arterial, it doesn't really make any difference. There's enough pressure to hold it open. You can completely obliterate a vein, femoral vein, for example, if your hand is just too heavy. And if you can't see it, ease up on your hand. And that's one of the ways that people actually look for DVT, for example. Is one of the things that the tech will do is they will show whether there's compressibility, because you will completely obliterate it. And it's also positional. So we did this yesterday with somebody up when we were doing ultrasound, scanning the neck. Carotid looks great. Where's the jugular vein? Can't even see the jugular vein. They don't have a jugular vein. They get the guy to Valsalva, and the thing's just massive. It's 3 centimeters. And so if you don't have the position patient properly, or if you compress the vein, you will fail. And so it's you got to practice going on and off the vein. And if you're not entirely sure sometimes whether it's an artery or a vein you're looking at, that's one of the ways you tell it. It's just blot it up and down. The vein is easily compressible. The artery is not. 18 gauge access needle, occasionally use that if we're doing venous puncture, but by and large it's been completely replaced with this. Guide wires, think of these as first in and last out. This is your wingman. Don't pull the damn guide wire out. It's just a disaster when you actually spend a lot of time navigating to a lesion, take a lot of time crossing the lesion, and then somebody pulls the guide wire out by accident. It will happen to you. And depending upon the complexity of getting there, it can really delay the case fairly significantly. And so think of these wires in a number of different ways. There are wires which you use to navigate to a target. Then there are wires which you use to cross the target. And then if you're bringing in a big device, like a stent graft, there are wires that you use to deliver these big stent grafts. And so a typical wire, what we use is, to get access, we use a Benson wire, okay? It's a floppy tipped wire, hard to injure things with it. And that's the safe wire to put up the aorta. And so when you get access, you put basically the sheath in the groin, you've got pulsatile blood flow, you pass the Benson wire. That Benson wire should be going easy. The next thing you do is turn on that image intensifier, okay? Guide wires can and will go anywhere, okay? So sometimes you access the groin, you put it in, you know you got it in probably about 18 inches, you floor, and you can't find the guide wire. And that guide wire can go completely down the leg, ipsilateral leg. It can go up through a superficial circumflex iliac. For example, patient starts complaining of pain towards their hips because the wire's basically up there. And those are tolerable. What is not tolerable is when it goes up and through a renal artery, and you will see perforated kidneys from guide wires that nobody actually knows where the end of the wire happens to be. In fact, we had a famous situation here where you almost never do bilateral renal artery stents except for stent grafts. And this was a board member who had bilateral renal artery stenosis, didn't want to come back, so got both sides done and got 2 perforated kidneys from a guide wire that went through it. Managed to stay out of renal failure. So there's wires. Benson wire is the wire that we access with. You can put simple catheters over. If the target we're trying to cross, let's say, is a contralateral SFA, then we'll probably change this out for a glide wire and cross the lesion with a glide wire. There are a million wires. You just need to figure out what the ones are that you're going to use, on a regular basis.
I was going to say there's a couple of language that he used a minute ago that I would re-emphasize. So there's sort of a navigating wire sort of gets you someplace, and that's typically, really, if you think about the wires, there's hydrophilics and non-hydrophilics. So hydrophilics have got some kind of lubricious coating on them that sort of make them super slick in your hand. They're much more likely to go places. We almost always use them with an angled tip because the advantage is you're trying to be able to navigate. Then you jump over typically the so-called working wires, meaning those are the wires that you're going to be delivering devices over. You're going to be delivering your balloons over working wires. And those are typically some kind of Teflon wrapped wire that's not, you don't really want to work over a glide wire. It's too slick. Somebody will pull the wire out, whereas a working wire's got a kind of a Teflon wrap around it that's very sticky and you can grab it. It stays where you put it. So the big wires like Amplats and Lunderquist, those are wires that we do a lot of work over. The navigation wires tend to be floppier. They tend to be, hydrophilic. They're easier to get, but you don't want to be working typically over a glide wire type of wire, or wire that's hydrophilic. The other thing we forgot to say, we should say one more time, is when you use those micro wires, we didn't emphasize it this morning, if you put in your micropuncture, you get it in, the wire's not advancing. You say, well, I got to abandon this. You pull back on the wire, and it doesn't want to come out. What do you do? So typically what's happened is you've gone beyond the point where the transition from the floppy tip of the microwire to the monofilament part, the stiff part, you start to pull back against your needle, and it won't come out. What do you do? And you're in there alone. What would you do?
Pull harder.
You could pull out the needle, but then you're going to lose your access. You'll leave a hole in the vessel. You can't flush because you got a wire in the needle. Sorry? You could try to rotate it a little bit, but basically if the wire won't come out, the last thing you do is pull harder, because you will shear that wire off on the tip of that needle. If you start to pull out a micro wire, it doesn't come out real easy, just abandon it. Pull the whole shooting match out and start over. You got a 21 gauge hole in a small vessel, it's not going to cause any harm, but don't pull this out, because I'm sure that Alan has, and I know I've had to operate on people and take out the tip of that micro wire where somebody got too aggressive about trying to pull back on it, and they just sheared the thing off. It's a very common mechanism of failure. And the tendency when you first do one of these things is you think, well, I've never seen this happen before. I'm messed up. I got to just get it out of here. And you try to just jerk it and run out of the room. And that's one option. You can just jerk it out, pull out of the room, and then blame it on cardiology or whoever accesses the groin the next time around. But it's not the best option. So generally speaking, if you're pulling a wire and you get resistance, don't keep pulling. Same thing can happen actually with glide wires, with the hydrophilic coating. You really never want to put a hydrophilic wire through a metal needle. They're meant to go through plastic stuff. You pull a glide wire out of a steel needle, and you can shear and peel all of that hydrophilic coating off and leave that stuck inside somebody. So generally speaking, pulling out things where you can peel off the sheath is a bad idea. Definitely don't do it with the micro wire.
So what happens, the wire comes on this. Sometimes there's just a weird angle here, and it gets kinked. And that transition is probably what's happening. It's just getting caught right there. And that's a sharp end of that needle. And so that's how this thing can basically shear off. So your options are drop the needle down in direction of the blood vessel, see if you can free it up, rotate it, it's fine. But by and large, you're just going to pull it out. And that's the advantage of having a micropuncture needle. It doesn't really matter. You don't get a big hematoma, which kind of challenges the next line of access. Just take it out, hold a little bit of pressure, basically, and re-access it. Just while I'm up here. So one of the things that John was talking about with glide wires. So typically you use an angled glide wire. And one of the areas you've got to be real careful with these is when there's a pre-existing stent, okay? Because what can happen is you try to recross a stent. What you don't want is for the guide wire to go through the interstices of the stent and get trapped. And we've all certainly seen that happen. So if you give me my slides back up again, that's why recrossing a stent that's in there can be done with a J-wire. So it's important to know all these different things. That's a very safe way of recrossing a stent. Or you happen to form a loop in the guide wire. Sometimes the tip of the guide wire gets caught. It forms a natural loop, and you push it, and it's going to find its way right up through the lumen of the stent.
Is everybody familiar with a Benson? So who does not know what a Benson wire is? Feel free to embarrass yourself. It's not a criminal thing. Benson has got a big, long, floppy tip. It's a cheap wire, it's a working wire, it's not a navigating wire, it's just a big old cheap wire, we use it a lot. But it's functionally a giant J. That's what it's for. The conventional J has a 3 millimeter radius on that loop. That's what it's called. The small J is usually called a Rosen. It's a 1.5 millimeter radius of the circle. A Benson is basically a giant J. So it's designed to go into a big vessel like an aneurysm, flip on itself. It forms a gigantic big J, but it's very safe because it's like a big boxing glove going up through stuff. You never perforate anything with a Benson because it's a big, soft, round, blunted tip that can go up in spaces. And that's what it, again, pick your tool for what it's designed to do. And Benson's very safe for going up through aneurysms. You can blindly practically take a Benson. Now, we're not recommending it, but you could, it's pretty hard to hurt anything with a Benson once it flips on itself because, again, it's like having a boxing glove on your hand. You'd have to hit something pretty hard with it to really do damage.
Yeah. So
and
again,
you can do a J, you can make a loop with a glide wire. So you can recross stents, but you intentionally, quote, flip the tip. Most of the time we're using a glide wire, we're intending to go up with the floppy tip because then what you're trying to do is find the lumen. Just like you do colonoscopy, you're kind of following the colon around wherever it goes. You're trying to see the lumen of the vessel. With a glide wire, with a glide angle tip, you're trying to make that thing find the residual lumen. Once you flip it on itself, so you now have a J, it's a little trickier. It can go, you can get subintimal, and it's almost designed to do that, meaning get behind the plaque in the wall and go up through the wall. But again, you're using it for a specific purpose, so that the tool can be used in different ways depending on how you use it.
yep. So, wires. Microwire, Benson wire, Amplat super stiff wire for delivering stents once you've actually crossed the lesion, glide wire for crossing lesions. If you start off by just knowing those 4 or 5 different wires, you'll be way ahead of the game. There are a million wires beyond our ability to talk to you about them. Frankly, I don't know them all. We kind of all work within a relatively small spectrum of the wires that we work with, but that's really what you need to know about. Sheaths and guiding catheters. So I think you looked at some of these sheaths yesterday. A sheath really is designed to give you access to a blood vessel without exsanguinating the patient. So there's a little valve on it. And it gives you a tube which connects the surface of the skin inside the blood vessel. So it gives you that vehicle by which you can deliver wires and catheters, then devices inside the blood vessel. And the nice thing about it, it's got a side port on it, so it does allow you to inject dye through this, where that may be important because these come in different diameters. An orange one is 7 French. They're all color coded, so you know exactly what the diameter is from looking at the sheath that you've got. Again, a diagnostic catheter can go through a 4 French or a 5 French. If you're going to put in a stent, you're typically working in the 6 to 7 French. It's somewhat variable. If you're going to put in an aortic stent graft, thoracic aortic stent graft, you may be using a 22 French. Those are specialized sheaths that you're actually going to utilize. This is a 9 French sheath. And they all come basically in this kit. They're back-loaded, and it's not because the manufacturer are crazy. That dilator is not in here, it's actually sticking through the end of this. You have to take it out and reinsert it. And that's so you can flush the whole thing in one piece. Hook up the side port, flush it, flushes the sheath, flushes the dilator, take the dilator out and insert it. And one of the mistakes that you see happening is if you don't have a big enough dermatotomy, then what happens, is as you advance this dilator, the dilator pushes back and you see the dilator at the hub separate from the sheath. Well, that means that you don't have a good transition. You don't have that nice tapered transition. So it's one of the things you need to watch is make sure that this dilator stays engaged and locked into that sheath because it can certainly push back. The other thing is we really don't use sheaths that don't have a radio pick tip on them. Again, if you're just using a short sheath, 7 centimeter sheath, probably not a big deal. But when you're putting a stent in an iliac artery, you're probably going to use a 25 centimeter sheath. And you don't want to deploy the stent inside the sheath, okay? And if you can't see where the end of that sheath is, it doesn't make any sense to use sheaths that have a non-radio arrow marker on the end of them.
It's funny because at our hospital, we have a big cardiology group at the Heart and Vascular Hospital in Dallas. So they tend to dominate what we buy. They don't care about bright tip sheaths because they're going in the groin and they're working on the heart. They couldn't care less where the tip of the sheath is. When you're doing an iliac angioplasty for an external iliac and you've got a 0.5 centimeter of access, And you've got to be very precise with how close you are to the end of your sheath, so you really need to know where it is. If you don't have a bright tip on there, it's really hard to see the end of the sheath, especially in a fat person. You've got a lot of, you even have to turn up your radiation, and it's hard to see, whereas a bright tip makes it much safer. So in general, as a vascular surgeon, you're going to want to use bright tip sheaths, because it does make your life a lot easier. The other thing, make sure when you may sometimes scrub for each other. You may have an opportunity to kind of serve as the first scrub on some of these cases, because some of your programs that's a quick way for you guys to learn, is to put you on the back table just kind of preparing stuff and handing it. Because believe me, we almost had to have a course called stopcock technology, because those damn things are not intuitive which way the hell you turn them. And all of us have done arteriograms where we had it turned the wrong way and we squirted contrast all over the room. Believe me, it's easy. The other thing, if you really want to mess somebody up, is you turn that stopcock, don't turn it off when you hand the sheath to them. So as soon as the dilator comes out, there's blood pouring out the back end of that sheath onto their shoe or someplace else. But you'll do this yourself by mistake. So always look at that check flow, the stopcock at the end of the sheath. Make sure it's turned off to the patient. Because again, it's not bleeding when it goes in because the dilator obturates it. As soon as the dilator comes out, now you got free flow out the side. And every single one of us have fouled this up, either because somebody handed us one or we inadvertently turned it the wrong direction. So it should be turned off to the patient.
So these are sheaths. Sheaths come in a variety of different lengths and shapes, but they're sized according to their ID. So if you've got a 7 French stent, what size of sheath do you need? 7 French, minimum, okay?
It's easy.
Sometimes it's nicer to have an 8 French sheath, so you can actually position the stent with the sheath close to the target and you can inject dye through it. If you put a 7 French device in a 7 French sheath, it's going to be pretty tight and you may or may not be able to actually inject dye through it. A guide catheter is a little different. It's like a sheath, but it doesn't have a hemostasis valve on it, so you got to put one on it, and it's sized according to their outer diameter. And so one of the ways you put a hemostasis valve on it is to put on what's called a 2E burst adapter. So this is a side port, and this is an adjustable valve. So it's one of these valves that you can take off the shelf, you can put it on there. So for example, when we deploy coils, the intracoils that Boston Scientific have, basically you deploy them through one of these 2E burst adapters. And so you need to get to use and play with one of these. The catheters we kind of think of, again, there's such a variety of these things, but you need to know what the shaft length is, you need to know what the shape of it is, and you need to know whether we call it a diagnostic, which is an end hole catheter. There's one hole, it's in the end. Or a flush catheter. Flush catheters are what you opacify big blood vessels with. If you take an end hole catheter and stick it in the aorta, and it's on the left wall, you'll get a nice arteriogram of the left wall of the aorta, because the dye will stream straight down the aorta. Same thing in inferior vena cava. A flush catheter is designed like this. It can be basically a bracket-shaped type catheter, or it can be a pigtail catheter, or it could be an omni-flush. These are all just catheters that got multiple holes around the end and on the shaft, and it sprays dye completely across the flow field, and will give you a really nice aortogram. And that's what I was saying about the information that's on the catheter itself. Will tell you what it's a 5 French catheter, so it's going to go through a 5 French sheath. You have essentially 65 centimeter working length, so the length from here to the hub is going to be about 65 centimeters. 65 centimeters will probably not get you up into the thoracic aorta. You need a longer catheter. You may need a 90 or 100 centimeter catheter in order to get you up there. And it tells you what the wire compatibility is. And the reason that's, it's not that you can't put these things over an 014 wire, but once again, that transition between the wire and the end of the catheter, there'll be a step off. And so we're always trying to minimize those step offs when they actually happen. And catheters can be thought of as simple. So this is one you gotta know, and that is the burn catheter. When you see a catheter that's 2 different colors like that, it's because they've got a radiopaque tip in it. Some of these catheters are very difficult to see. You really need to see where they are. And so manufacturers can enhance the visibility by embedding, basically, I don't know what it is they actually put in it to make it more radiopaque. And this is a simple curve, a burn catheter. This is your working horse catheter. A burn catheter, a Benson wire, and a glide wire, or what you're probably going to use in 60–70% of your cases. And this is just an example. This is actually from a pig where, the upward sloping renal artery is the perfect angle in that to actually catheterize that. But sometimes what happens is the renal arteries, for example, are downward sloping. And that's a situation where you need a much more complex curved catheter. So here's a downward pointing catheter. Problem is when you put these in, they go in over a wire, so they go in straight, and you got to reform them. Now, if you've got a nice big aorta, you pull the wire back, that whole catheter may just reform, and then you pull it down to the target. This is the renal. You pull it down and engage the target. But sometimes this sweep from here, these are the secondary and tertiary curves here, are too long for the aorta to allow it to reform. And so you reform it in the aorta, and it goes, and it can't do what you want it to look like here. Sometimes you can push the catheter up and it'll reform, and there are 3 different ways in which you can reform them. We don't want to go into that today. So these are some basic catheters you need to know about. This is examples of a whole variety of different flush catheters. You use these, you're going to get a nice opacification of the aorta. So you need to position, for an infrarenal aortogram, you want to position that catheter probably right above the renal arteries. If really standards, we want to see the whole span of the infrarenal aorta. And then you're going to hook it up to the power injector. So anybody use the power injector? Okay, so you've got your diagnostic catheter, here's the hub, here's the tubing, high pressure tubing coming from the power injector. Anybody want to take on the sequence? How you connect these things together? All right, I'll go through it. So you're looking at the blood. You basically have this open end coming from the power injector. You tell the tech, wind forward, or bump forwards, whatever he says. What he's going to do is wind forward, and you'll have dye coming out of the end of it, and you do a fluid-to-fluid connection, okay? You lock that on pretty tight. That thing blows apart. You're going to be covered in dye. And then what you'd say is back, okay? He's going to wind this back, and you want to see that transition, an interface between the blood and the interface between the dye. You don't want any bubbles in there, okay? And if there's bubbles in it, you either disconnect it and go through the whole thing again, or if there are a lot of bubbles, they'll say, I'll just take it all the way back. And they will wind that column all the way back into the power injector. And then they will basically tip the power injector down, bang on the power injector to all the bubbles at the back end of, let's say there's 100 cc's in there, we're only going to inject 20 cc's. But it's a sequence you go through every time, okay? It's not one of these things you take shortcuts on. If you inject a couple of bubbles into somebody's abdomen, probably not that big a deal. You inject that up into somebody's carotid. It's the difference between having a stroke and not having a stroke. So it's very important that you get these sequences down and that you understand how a power injector works. Because what they're going to want to know is how much, how fast, and what pressure, okay? And those are the things, so typically you'll learn this. So for example, for doing an aortogram, typically you'll say 20 for 20. All right, what does 20 for 20 mean?
20 cc's of contrast for 1 second.
1 second, exactly. Yep.
This one for 40, we go for 2 seconds.
Very good. And then they'll say, what PSI? They usually don't ask you this because they know enough about it to be able to do it. Yeah, so 800, 900 PSI, something like that.
What is that? So they're given the total volume and you're given the rate. So you could give, 30 for 7. What would that mean?
30 cc's over 1 second for 7 cc's.
It's that total 7 Cs. Yeah, we used to use it at Cleveland Clinic to just a little bump at the renal arteries. It was a fast bolus, but a total volume of 7 cc's, a little quarter-second type of a pump that just was to flash the renal arteries. So again, you're given a rate, you're given a total volume, and then this pressure thing, I think, confuses everybody. What is that pressure? It's a pressure limit. It's not the pressure you're injecting. That pressure should be determined by what, if you go back one slide, Alan, I think it was see that thing that says burst pressure? That catheter has a defined burst pressure. And what it means is if that catheter had a knot in it, and you hit it with 1100 PSI, it would burst. It's defining the quality or the burst pressure of the tubing. So for instance, if you were gonna, let's say some people put a stopcock between the catheter and the power injector. Some people think that lowers the chance you're gonna get bubbles. Personally, I think it increases the chance you'll have bubbles because you have another mechanical device that you flip back and forth. But some of your attendings like to use a stopcock there. But let's say you inadvertently turned the stopcock off. So now you hit the power injector and it's injecting against a fixed obstruction. That pressure curve would hit 800 and it'll stop injecting, and it might inject whatever. And at the end of each injection, you can see, it'll tell you what the maximum pressure was reached for that piston to push that volume of fluid forward over that time period. and it'll say it hit 475 or 500 or something. It hardly ever goes very high unless you've actually got it up against an obstruction. It's a safety limit. It's not the amount of pressure that you're injecting. And so you think, oh, that's how hard I'm pushing. It has nothing to do with how hard you're pushing. It has to do with the pressure limit. If the device hits that limit, it stops injecting. It's a safety limit. So you can put it at 800, 900, 1100. You'll almost never go over it. But the easiest thing to do is look on the label. Every one of those catheters has a defined pressure, burst pressure, and that's actually the pressure you should use if you wanted to be technically, safe. That's the safe thing. 20 for 40 at 800 is going to get you through 90% of these things if you want to do it that way. 15 for 20, whatever you're injecting at 800 is going to be safe. But it's not the pressure you're injecting, it's a pressure limit that's set on the machine. To change how hard it pushes, there are some settings that ramp up the pressure instead of a square wave function, so you fully maximize your push immediately. You can ramp up with a half a second or whatever before you hit your peak pressure, so it slows it. So for instance, if you're injecting into something like the SMA, and you don't want to take the tip of that little Simmons catheter and just pop it out, and if you hit it with a full force, sometimes you don't have enough catheter in the side vessel, there's so much ejection force that it'll just blow it out. And you can ramp it up by slowing up, change the shape of the upstroke, and you're getting into stuff that you'll figure out by the time you're a chief resident. But I think the main thing is someday, it won't be long, you'll be in there and somebody say, well, how much do you want to inject? And you're going to go, I don't know, this pressure limit thing's freaking me out. Just tell them, 10 for 15, 800, you'll be okay most of the time. But know that limit is just the pressure limit for the mechanics of the device.
So this is just really to emphasize that these catheters come in series. So you get C1, C2, you'll see SIM1, SIM2, SIM3, and that relates basically to the diameter of the catheter. Really, the idea is that when you're using this device, is that the shaft is going to butt up against one side of the aorta, and that this is going to be on the other side of the aorta, and it's going to hunt and peck for the orifices that you're trying to target. And so if you're somebody who's got a big aorta, you need bigger diameter. And that's why you see catheters with different series of diameters associated with them. The angioplasty balloons you're going to see have a couple of things associated with them. There's the length of the balloon, the diameter of the balloon, and the shaft length of the balloon. And it'll also tell you the burst pressure is in the balloon. And these balloons have radiopaque markers, just like this, okay? And that's what you see, okay? When you put the balloon in, you don't see the balloon. But there are RO markers which show you where the beginning of the shoulders occur. It's not the total length of the balloon. It's where the balloon edges are parallel with one another. And so some of these balloons vary in the length of the shoulders. And so you got to be real careful sometimes when you're putting in an aortic endograft and it transitions from a big common iliac aneurysm into a small external iliac, that if you have that shoulder projecting into the external iliac and you blow it up and you're focused on the end of the stent graft, you can rupture the external iliac. You just kind of need to know what those characteristics
The
of the
bigger the
balloon.
balloons tend to have longer shoulders. Some of those, say a 14 millimeter balloon, some of those things have got 2 centimeters of shoulder on each end. And you say you want to put something in your common iliac, you're trying to dilate, but the shoulder is hanging out in the external, you can have a pretty big balloon well beyond where the markers on the balloon appear to be. So again, these are things that are beyond what you need to know right now, but set it in the back of your head and just remember these little markers, they're not square waves. These balloons are not square on the ends. They have to have some shoulder, and it's all defined by kind of what the material is and how high the pressure is they're supposed to limit and all that.
So when you look at the balloon catheter itself, there's always a guide wire port. Like everything else, they go in over a guide wire, and then there's a balloon port. And so this is where you put your endoflator on to blow up the balloon. This is kind of where you flush and then pass the guide wire. You don't want to put the endoflator on here. It doesn't work very well, but we've all probably made that mistake at some point in time. When you start blowing up the balloon, the balloon is inflated with a mixture of contrast and saline, okay? And typically it's about 10-15% contrast. Because you want to see the balloon. You see the balloon as it expands. And what's reassuring is if you've got a lesion like this, you will see the ends of the balloon flare up first of all. So it looks like a dog balloon when you actually do this. And that's reassuring. Number one, you got the balloon in the right place. And number two, it also anchors the balloon. One of the challenges you'll get with very resistant lesions is we call it melon seeding. So melon seeding, spit the melon seed out, same thing happens here. If you don't have it centered, then what happens is the front end of the balloon that's not in the lesion blows up, and the balloon pops forward. And so sometimes you need a longer balloon, but when you see a balloon blowing up like this dog bone, it's not going to extrude, and you're going to be able to blow it up. And you look for the balloon to come up and show parallel edges. So we come up to profile is the word that people use. So it's in place, it's going up, it dog bones, it's up to profile. And when we come up to profile, we say, hey, what is the rating on this balloon? They'll tell you what the pressure rating is to bring it up to profile and what the burst rating is. And by and large, once you come up to profile, you don't really need to put a whole lot more pressure on this in arterial lesions.
Why do you not use 100% contrast in one of these inflators? It's too viscous. And if you, especially in small balloons, remember they're just a little capillary tube that's carrying this fluid down to the balloon. If you put pure contrast in there and you pull back on it, some of these balloons won't deflate. The stuff is so viscous, it gets in and it won't come out. So you want enough contrast to be able to see it, but you don't want so much that it's going to be hard to deflate it. Big balloons, it probably doesn't make that. They've got a big bore channel, and you could put 50% contrast and probably be fine. But for the small bore stuff, if you put very high viscous contrast in there, you'll never get it back out. And you have to have tricks. Sometimes you have to have tricks to burst balloons in order to get them out of tricky situations. But that's the reason you don't use pure contrast in the inflation.
So there's blowing it up, and then there's taking it down, okay? And when you take the endoflator, you essentially suck negative pressure, and there's a quick release that allows it to hold negative pressure. And if you look at the endoflator, you'll see contrast flowing back into it. And a lot of people just look at that and will not turn on the fluoro until that ceases. You return on the fluoro to make sure that balloon is deflated, okay? You do not pull these balloons out until you've checked that they're deflated. And there's another mistake you'll see all the time. Because if you pull a balloon out that's partially inflated inside the stent, you may well drag that stent out of position. The other thing that can happen when you blow up a balloon is the balloon busts, okay? So you're cranking it up and the pressure comes up and the pressure drops. And you crank it up again, the pressure comes up and it drops. You go, shit, probably bust the balloon. Sometimes you turn on the fluoro and you can see a little piece of contrast leaking out of the balloon. The other thing you do is you pull negative on the endoflator and you'll see blood coming back into the chamber. And that's a sign that the balloon has ruptured. And a ruptured balloon, these balloons are designed to refold when you actually deflate the balloon in very specific ways. Once it's ruptured, it doesn't come down to the same profile as it was to start with. So again, if you've got a stent in there, you want to mag up on that stent and you want to watch that stent as you take that balloon out of it to make sure that the ruptured part of it is not engaged on the stent and is hanging up on the stent. That's the advanced course you have to come back for when you end up screwing it up like that.
Generally speaking, it's not a good idea to move balloons while they're still partially inflated. I mean, I think that's the bottom line. Generally speaking, you want to have them fully down. Some people will prefer you on your deflation, particularly this was popular in carotid stenting, was not to just pop the balloon down, was to crank it to 0 and then put it on negative. That somehow that if you just popped it from a fully expanded balloon down to 0 or negative, that it created some kind of shock waves or sort of vibrations that were more likely to create embolism, particularly if you were doing like a pre-inflation, you didn't have a cerebral protection device. I'm not sure if that really was happening, but it is common to see people, when they initially take it down, just crank it to 0 and then disengage the thread so that you can bring it back to negative. It may be a little less abrupt than if you just pop it all the way back all the time. Again, your attendings are going to have very precise sort of feelings about all this. So again, what problem are you trying to solve is the question. How you solve it is going to be what you learn over the next 5 years.
Stents, again, two broad categories: balloon expandable stents and self-expanding stents. Balloon expandable stents in general are used for things like the iliac and the aorta. The new twist on balloon expandable stents is covered stents. And so VBX, basically from Gore, is one example of that. And basically it's a balloon expandable stent that's covered in PTFE. It's what we use, for example, for fenestrated grafts. When you go to an aortic iliac bifurcation, you really can use either. They're more expensive if you use a covered stent than if you use a balloon expandable stent. When John and I were boys, you had to actually mount your own stents on these balloons. That was a nightmare, to be completely honest with you, because you actually had to take the stent and crimp it on the balloon. Well, guess what? That means it's not on there very securely, and if you take it through a stenosis, it pushes the stent off. Now they're so well placed on these stents, that is very, very unusual. But, for example, the way that you protect yourself against this is if you're coming from the groin up through an iliac, you cross the iliac with a wire, and then you usually put a sheath across it, okay? And so the balloon and the stent is brought up inside the sheath, positioned inside the stenosis, and then you pull the sheath back. And you leave the sheath probably 3 to 4 centimeters from that. You can puff some dye in, you can make sure the stent is still in the right place, and then you blow up the stent. And if by chance the balloon ruptures and it's hanging up on that stent, then you've got a sheath there that you can advance up inside and kind of core this thing out from the inside of the stent. So by and large, if you're going to put stents in, you want a long sheath that will go beyond the target point where you're going to be deploying that stent. Self-expanding stents tend to be used predominantly in lower extremities. They're heavy utilization, in the lower extremities. And one of the reasons for that is there's a lot of extrinsic compression and rotational forces. If you put a balloon expander, the first carotid stents were balloon expandable. They all got crushed. If you put a balloon expandable stent in the celiac artery, because of the median arcuate ligament, it tends to get crushed. You put it in the groin, it's going to get crushed. So anywhere where there's a lot of extrinsic compression forces at work, you tend to use a self-expanding stent. And then, of course, this whole thing is expanded because of the use of drug-eluting stents, predominantly in the lower extremity. And they're, by and large, all on a self-expanding platform, which is made of some kind of nitrile.
Yeah, generally speaking, I mean, again, if you were left alone on a desert island, go fix this thing. Generally speaking, we use balloon expandable stents when you're in a body cavity. They tend not to work very well when you're outside. When you're in extremities, you're in the neck, they're just exposed to compression. Sometimes little short balloon expandable stents can be effective, like in tibial vessels. A lot of people will use little coronary balloon expandable stents, but generally we don't use them outside the body cavities because of the risk of compression. The only place inside the body cavities where you have risk of compression is at the celiac because of the median arcuate ligament. We tend not to like stuff sitting between bones, so between the clavicle and the first rib. Again, some of your attendings will do things and sometimes, we do things that we don't agree with. I mean, let's face it, vascular surgery, there's a lot of different ways to skin a musk ox, and we all have different opinions about how to do it. And you're going to all get different, but at least have some of the background. So generally, you got balloon expandable, self-expanding, uncovered, and covered. Big categories, different reasons to use them. You're going to learn that over the next 5 years.
Okay, I think we're going to call this session.
Any questions, any stuff that kind of comes to mind that just immediately you say, wow, I was told something radically different than that, or I've heard such and such, or anything that kind of is conflicted that, again, the purpose of this kind of a course is for us to learn from each other. And that's two-way street, believe me. Alan and I have learned a lot from these courses, from you guys and from the people who've trained you. So it's an opportunity if something just doesn't really fit. This is a great opportunity to exchange it with all of us so we all get a chance to benefit. Any questions on stuff that you've seen? All right, well, let's go up to the lab.
Tyree needs to say a couple of things. We're actually, so upstairs, he's going to tell you about it, there's going to be we've never done this before, so this is kind of an experiment. You're part of an experiment. And there's a 360 streaming camera that he's going to tell you about that we're going to stream out live out of that cadaver room. So it also has microphones on it, okay? So number one, be respectful. Number two is be a little careful of what you're saying. Go ahead. That goes for you too.
Hey, everybody.